Hi guys, so welcome back to my channel Dr. Z, the AIIMSified WombWhisper. So today I'll be talking about the topic of basic antenatal care. So it is a must know topic and we all should know it, be it if you are a MBBS student or an intern or a post MBBS practicing anywhere as an medical officer or RMO or whatsoever. If you are a PG student, be it DNB, MSMD or even an SR and a nursing officer or a nursing student, we all should be knowing how to provide basic antenatal care to a pregnant patient. Okay, and this is a must know topic. We cannot mess with this topic. So here I have taken the reference from Williams Obstetrics, which is the Bible of Obstetrics book, and 25th edition, and from Disi Datta. Okay, so uh, I am so fond of quotes. So this is one quote from the Williams from the chapter of prenatal care. So here it's written that the borderline between health and disease is less distinctly marked during gestation, and therefore it accordingly becomes necessary to keep pregnant patients under strict supervision and be constantly on the alert for the appearance of any untoward symptoms. So there is a very thin line between when a pregnant patient is fine and when she can go wrong. That is why we need to check on our pregnant patients every now and then to provide them care in every visit and to call them frequently. It's not like once you see in 1 month and then in 9th month. So that is why a designated follow-up period is designed for these patients and what to be done in these follow-up visits. Okay. So what is the objective of basic antenatal care? To ensure a normal pregnancy and delivery of a healthy baby from a healthy mother. You do take history from the pregnant mother and do examination, both general and obstetrics, and you give some advice to the pregnant mother on medication, vaccination, any investigations need to be done, be it blood investigation or any ultrasound investigation, and when to follow up. Okay, so when we take history from obs patient, so how does it help us? History taking an examination, how does it help us? It helps us in screening high risk cases. So high risk cases have some additional management. In those patients we have some additional management, regular more frequent follow up, more investigations, more number of ultrasounds and more number of consultations from interdepartments, from different departments. We need multidisciplinary management in some high risk cases. So that is why it is very important to screen the high risk cases, because the care we provide to a normal ANC patient and to a high risk case is different. And here I'll be talking about normal ANC cases in this topic only. Okay, then we screen the high risk cases, then that is how we prevent development of any untoward complication. In those cases we prevent, detect and treat whatever complications we find at early age to prevent maternal and fetal morbidity and mortality. Then we ensure continued risk assessment and care. We discuss with the patient about the high risk factor in them and how we are going to manage it further. Then we discuss the place, timing and mode of delivery. Okay, so like place is very important. Some high risk cases are needed to be managed in a tertiary care hospital. You cannot manage it in a PHC or a CHC. Okay, because most of the time in those high risk cases we may need blood bank, anesthetist, neonatal ICU, ICU for mother, ventilator setting. So we might need one or more of this in many high risk cases, and that is how we decide where to deliver these patients. And contraception is very important. We should discuss about contraception during ANC period only. We should give mother the options and help her choose the best contraception for her. Okay, because mostly patients should be motivated during antenatal care only, antenatal visit only, because patient might not be able to think about it during intrapartum or postpartum period. So it's better to discuss about contraception during their antenatal visits. So, how many trimesters are there? As you all must be knowing, there are 3 trimesters, also known as epochs, of 14 weeks each. So, 0 to 14 weeks it is first trimester, up till 28 weeks it is second trimester, and then up till 42nd week it is third trimester. So what do you do in first visit when patient comes and she complains of amenorrhea or missed period? First you need to do a UPT. Patient may come with home UPT also. You should repeat it and in your setting and then see. So we do UPT, urine pregnancy test, and when it comes positive, then we calculate period of gestation from her last menstrual period. We take proper history like I have taught you earlier. We do examination. In examination, in like in first visit, it is an opportunity to screen the patient for cervical cancer. So pap smear is taken in most of the cases. So we do PAs, pap smear, and pelvic examination to know about the size of the uterus. And also in some cases, if you are suspecting ectopic pregnancy, then pelvic examination will give you some information about the same. Then after taking history and examination, we tell patient to take some supplements, vitamins, iron, folic acid, whatsoever, depending upon her period of gestation. And then we advise her some blood test and ultrasound scans or dating scan, I'll tell you later. And then we advise her to stop if she has habit of smoking or alcohol intake or any illicit drug use. And then we tell her when to follow up. Okay, so these are the first things we should be doing in first visit. A little about beta HCG as it is very important. So beta HCG is a heterodimer. It has 2 subunits, alpha and beta. Alpha subunit is identical to LH, FSH, TSH, and beta subunit is distinct. So antibodies are developed with high specificity against this beta subunit. That is how we detect it in urine or serum in blood. And many immunoassays are available for measuring serum and beta HCG levels in urine also, like we do Prega News and etc. for UPT. Beta HCG is produced from syncytial trophoblast. There are cytotrophoblast, syncytial trophoblast, all these structures as we had studied in embryology. So it is secreted from syncytial trophoblast, and the main function is to maintain the corpus luteum up till 6 weeks till placenta develops and takes its function. And what is which hormone is important here? Progesterone. So it is important to prevent involution of corpus luteum. Corpus luteum will be producing progesterone till 6 weeks, and then a placenta will develop, and then it will start producing progesterone itself. Till then corpus luteum should be maintained. And beta HCG you can detect in maternal serum or urine as early as by 8 to 9 days after ovulation, and doubling time is 1.4 to 2 days. Peak level is reached at 60 to 70 days after fertilization, and then the concentration declines and takes a plateau by 16 weeks and remains at that stage only. In some cases you may get false positive UPT, means you told patient to do urine pregnancy test, it came out to be positive, but patient is not pregnant. So what are the cases where there can be false positive UPT? So first is heterophile antibody. Some women who have worked closely with animals can develop some serum factors in heterophile antibodies, which will give you false positive UPT. Then in cases of molar pregnancy and associated cancer like invasive mole or choriocarcinoma, etc. In some patient may be taking HCG injection for weight loss. In those cases also UPT can be false positive. Renal failure with impaired HCG clearance, physiological or HCG producing tumor originating from GI sites, ovary, bladder and lung. So these are rare, these 3 are very common. So you can just remember 2 to 3 points, that's enough. So what is dating scan? From the name only you understand that dating scan is to date the pregnancy. Normally it is done around 7 to 9 weeks. Okay. So it is used to accurately establish gestational age and confirm pregnancy location. So there are some sequence in which you can see how intrauterine pregnancy develops. So first is gestational sac, also known as G-sac, then there is yolk sac, and then there is embryo or fetal pole. Okay, so in this sequence only intrauterine pregnancy develops. So G-sac develops by 4 to 5 weeks when you see by TVS, transvaginal ultrasound, and when you look by transabdominal ultrasound, you add just 1 week more. So by 5 to 6 weeks in transabdominal ultrasound, you will be able to look for gestational sac. It is the first sonographic evidence of pregnancy, and it is a small anechoic fluid collection within the endometrial cavity. There is one question: what is true gestational sac versus pseudo gestational sac? So true gestational sac is eccentric. It is developed at one, at one side of the uterus, but pseudo gestational sac is central. You can see it in the central, and true gestational sac is in intrauterine pregnancy, but pseudo G sac you can see in ectopic pregnancy. Then comes yolk sac. It is an echogenic ring with an anechoic center within the G sac. So if this is uterine cavity, and you can see G sac, yolk sac will develop inside G sac. Okay, and you can see it by middle of 5th week by TVS scan, and by transabdominal by middle of 6th week. Okay, you can see yolk sac. Then comes embryo. You can look for embryo after 6 weeks. It is a linear structure which develops adjacent to the yolk sac. So it develops adjacent to yolk sac, and that is how we see the cardiac activity in the fetus, fetal cardiac activity, and we also take the crown drum length. This gives us the period of gestation. Then we correlate this period of gestation from period of gestation we got from LMP, and then we see if these are correlating. If it is correlating, then okay, LMP is correct. If not, then patient might have forgotten her LMP, or her period itself is irregular. So in that case we take dating from scan. Okay, so that is why dating scan is important to establish the gestational age in accurate way. It can be done up till 12 weeks, and crown drum length is predictive of gestational age. So what are the investigations you advise patient? In first visit, you should tell all these investigations to do: blood group, hemoglobin, TSH, viral markers. HIV is an opt-out test. Patient can opt out. She may deny, she does not want to do HIV, and it's we just cannot force her to do it. Okay, so this is an opt-out test. VDRL DIPSI is diabetes in pregnancy study group India. So Indian guidelines say that whenever patient is visiting us for the first time, that time only we can do test to rule out diabetes in the patient. So here fasting is not needed. There are other tests also like OGTT, oral glucose tolerance test, which we do after fasting. Then we take patient to take oral glucose 75 milligram. So these are some little cumbersome. We need patient follow up in those cases. So in Indian setting, where we are most likely to miss patient, or patient might drop out, they may not follow up, and already India is the diabetic capital. So to screen more number of patients, we have started doing DIPSI in first visit only. Here fasting is not needed. You just give patient oral glucose, and then we take a 2-hour post meal value, post glucose value, and then there is some level below that it is not diabetic, above that it is diabetic. I will tell you about all these. So you can do DIPSI or fasting blood sugar and postprandial blood sugar in first visit itself. DIPSI is recommended. So in upcoming videos I will tell you about diabetes in pregnancy. There itself I will tell you about different guidelines for screening and diagnosis of diabetes in pregnancy and its further management. So for the time being, for this chapter, just remember we do all this thing in first visit. and also urine for the presence of protein and sugar and bacteriuria. We also do rubella IgG and IgM to see if the patient is immune for rubella infection or not. If she had been immune earlier, then it's fine, you don't need to do anything. If IgG is negative, then we give rubella vaccination immunoglobulins to patient. Okay. Then in subsequent visit, when patient will visit us at after some interval, whenever we call her, then in this particular time period you need to advise these investigations also. So at between 11 to 13 weeks plus 6 days, we need to advise patient for aneuploidy screening, which is also known as dual marker and NT-NB scan. Between 18 to 22 weeks and by WHO up till 24 weeks, we advise patient for fetal anomaly scan, also known as level 2 scan. Then between 24 to 28 weeks, we advise patient for GDM screening by oral glucose tolerance test, OGTT. Okay. Between 34 to 36 weeks, we tell patient to do one growth scan. So during whole pregnancy, only 4 scan is needed. One is dating scan, second is NT-NB scan, third is level 2 scan, and fourth is growth scan. In case of normal low risk pregnancy, I am not talking about high risk. In a normal low risk pregnancy where there is no other comorbidities and patient is all fine. Okay. And Government of India says to estimate hemoglobin 4 times during pregnancy. As you know, anemia is very common in ANC patient. More than 50% patient are anemic here. So first we do at registration, means at first visit, then again at 20 to 24 weeks, then between 28 to 32 weeks, and once just before when patient is term by 36 weeks we do again. Okay. And in case of Rh negative pregnancy, if patient is has Rh negative blood group and husband is Rh positive, and at first time you did ICT negative, then again you repeat ICT at 28 to 29 weeks, and again if it is negative we give patient anti-D injection to prevent Rh isoimmunization. Okay, this also I will cover in another video about Rh negative and Rh isoimmunization pregnancy. So all this investigation you need to keep in mind. And what are the interventions we do in pregnancy? What are the supplements we provide? So preconceptionally, as we all know, we tell patient to take folic acid to prevent neural tube defect in the fetus. So folic acid 400 microgram daily for at least 1 month, and best if she can take till 3 months before pregnancy. And after conception we tell patient to continue till first trimester. Okay, then after a patient which is in second trimester, when second trimester starts, we tell patient to take iron supplements, iron and calcium supplements. So iron folic acid tablet, what is available in government settings free of cost in most of the places. So we tell patient to take iron folic acid tablet, 1 tablet daily from second trimester till delivery and up till 6 months postpartum. So different guidelines say different thing. In India we follow Anemia Mukt Bharat, where we give 60 milligram of elemental iron with 500 microgram of folic acid in 1 tablet from second trimester and continue throughout pregnancy for a minimum of 160 days and till 180 days till postpartum. Okay, means 6 months postpartum. And WHO says 30 to 60 milligram elemental iron plus 400 microgram of folic acid, same from second trimester till 3rd month postpartum. So don't get confused, this is what we follow in India. And we also give calcium supplement. We give 500 milligram calcium tablets twice daily, or you can give 1000 milligram OD once daily. So we give folic acid, iron and calcium supplements to a normal ANC patient. Immunization, this also I will talk in details in upcoming videos about immunization and vaccination in pregnancy. For the time being, just remember, earlier we used to give TT, tetanus toxoid, but nowadays in most government settings we have TD injection, tetanus plus diphtheria toxoid, 0.5 ml IM in upper arm, 2 doses 4 weeks apart. So first dose you can give in first visit only or by 16 weeks, and then you repeat the second dose after 4 weeks. And if a patient had been pregnant in last 3 years and she has already received 2 doses in that pregnancy, then you need not repeat 2 doses again, you can just give a booster dose. Okay. And this is another one, Tdap, tetanus, diphtheria and acellular pertussis. This is the recent one and very effective. It covers pertussis infection also, which is very common in infant up to 1 year of age. So it prevents pertussis also. So this is very good, but not available everywhere, not free of cost. So wherever it is available and whenever patient can afford, we always prescribe Tdap. Only single dose is needed, single IM dose between 27 to 36 weeks. It's not like you cannot give Tdap to patient who has received TD. So if a patient has already received suppose TD, 1 doses or 2 doses, you can still give Tdap to that patient. Okay. Now dietary advice, what will you tell patient, how to take her diet, how much to increase and how much weight gain is expected. So as per ICMR guidelines, average weight gain of 10 to 12 kg is enough for a normal ANC patient, and additional calorie of 350 kcal per day. So whatever is recommended for her, for her activity level, sedentary, then moderate activity and then heavy activity, all these have different calories requirement. So as per a normal non-pregnant patient calorie requirement, as per that level of activity, you just tell her to take additional 350 kilocalories during second and third trimester. No need to increase calorie in first trimester, as there is no significant weight gain for immediate for baby also. So this is how the breakdown is: 0 for first trimester, 340 for second trimester and 452 for third trimester. You need not remember these numbers, you can remember or whatsoever, but if you can remember this 350 additional calorie, then that is enough. Okay. And protein intake is 1 gram per kg per day is recommended. So here I have given breakdown. You can see ICMR 2020, for non-pregnant and pregnant patient, this is how the calorie requirement is given as per the level of activity. And protein requirement for an adult woman is 55 gram per day plus these additional, like for in first trimester 0.5 gram per day, more is needed, then in second trimester this much, third trimester this much. So it's fine if you remember 1 gram per kg per day. Now follow-up visit. So when will you call the patient next again? So what we follow and what is given in Williams and DC Datta also, up till 28 weeks you call the patient 4 weekly, then 2 weekly up till 36 weeks and then weekly till delivery. Okay. And Ministry of Health and Family Welfare says at least 4 visit is mandatory and needed for a proper ANC, for at least minimal ANC care which we can provide to the patient. So first visit is the registration visit, when patient visits you for the first time as soon as the pregnancy is diagnosed up to 12 weeks. Then second visit between 4 to 6 months, third visit between by 8 months and fourth visit by term. And WHO ANC model says minimum of 8 ANC contacts are needed. First in first trimester up till 12 weeks, 2 contacts in second trimester and 5 contacts in third trimester. So just remember at least 4 ANC visit is needed, and as per WHO at least 4 ANC contact is needed. And what we do is this. And what do you do in subsequent visit? You are calling the patient again after this many weeks. So when patient visits you again, you assess the well-being of both the mother and the fetus. So you ask the patient about appearance of any new symptoms or date of quickening, or if there is worsening of any persistent symptoms or any comorbidities, as you see if it has worsened or not. Then you do general examination, you check for weight gain, pallor, pedal edema, BP. You do examination after 22 weeks, you see the fundal height. Then as the pregnancy grows, you look for fetal life stage, clinical, how liquor appears, then engagement of fetal head, and so. And by after 37 weeks or by 37 weeks you do pelvic examination. Okay, from this we know if a patient we can allow the patient for vaginal delivery if baby is appropriate to go vaginal delivery uh, for that patient, and what is the indication when we don't do PV examination. As we all know, placenta previa. And what advice do you give in each visit? Again, on diet, I have told you, if patient is in second or third trimester, you tell her to take additionally 350 kcal per day extra plus 1 gram per kg per day protein. You tell her to have daily fetal movement count checked at least 10 or more than 10 per day in 24 hours. Okay, so you tell the patient to after each meal in morning, daytime and night time, after each meal for 1 to 2 hours to keep her hand over the abdomen while she is walking or sitting or lying down, and just try to feel the movement of the fetus. So if in 1 hour she is feeling 3 to 4, that is enough. So in 3 times when we add it up, it is more than or equal to 10, that is enough. If it is less than that, she needs to report to the emergency in the hospital with decreased fetal movement. You explain the patient about the warning signs if there is any pain abdomen, leaking per vaginum, bleeding per vaginum, or any signs symptoms of preeclampsia, headache, blurring of vision, dizziness or fever, vomiting, diarrhea, whatsoever. So if all these are patients, she should just consult her nearest doctor or visit the hospital in these cases and review SOS as and when required. And about the timing of delivery, we already calculate estimated delivery date from Niggles formula. So we give a date to the patient, whatever comes from her LMP, and after 36 weeks already she is visiting us weekly, so we are assessing her already. At 37 weeks we look for the pelvis if it is adequate or not, and we tell the patient to come to emergency if any of this happen. Her EDD is given at 48th weeks. In most of cases, if labor does not happens by its own, in as per institutional protocol, we induce the patient by 40 or 41st week. It is as per institutional protocol. So these are all the basic things regarding normal ANC care, antenatal care, and we should all be knowing this. And thank you for watching the video. I hope this has been beneficial for you people. So please subscribe to my channel and like the video, and in case if you have any doubt, you can ask me in the comment section. Thank you.